At the same time, we try to approach this COVID topic from slightly different perspectives. What kind of changes we are facing in response to the COVID-19 situation? And some of them are quite positive. So we observed simplification of some patent regulations, simplifications of some programs for HIV prevention and methadone program, for example, amnesty for drug users. So we are trying to focus during this live discussion what kind of changes we need to sustain, what kind of changes are actually quite positive and should be kept beyond peak of the COVID epidemic. Alliance for Public Health within the SOurce project organized this webinar with involvement of great four experts, Volodymyr Kurpita, Fifa, Rahman, Anton Basenko, and Niamh Eastwood. I'll introduce speakers in details while they will be delivering the presentations. And now a couple of words on the logistics. So the webinar is in 2 languages. You can ask questions during the sessions, and we will answer questions at the end of the session. For the questions, we would like to ask you to send questions to put them in the chat box, so we can we can put together and speakers can respond at the end of the session. We would like to ask you to put questions while speaker is actually speaking or right after that, to connect questions with the speaker. I think it's a great opportunity and great timing for the session. We can actually start, and I would like to introduce our first speaker, Volodymyr Kurpita. He's an expert on public health and HIV/AIDS from Ukraine. Volodymyr also CEO of newly registered NGO Center for Human Capital. Volodymyr, the floor is yours. Please introduce your topic, and colleagues will see presentation on the screen.
Okay, thank you, Andrei. For the introduction, I was asked to present the lessons and opportunities which the health sector was utilized from the from the COVID pandemic. I hope the slides will come soon. And my presentation will be the longest one, and but I will try to keep the information very short. Thank you very much. So the slide is here. Let's back to the first slide. Okay, yes, starting with this, I would remind the health system can be understood in many ways. WHO defines health system as all organization, institution, and resources that are devoted to producing health action. And this definition includes a full range of players engaged in the provision and financing of health services, including the public, non-profit, and for-profit private sector. The WHO report 2000 identified the 4 key functions of the health system, which is stewardship, often referred to as governance or oversight, financing, human and physical, and organization and management of service delivery. The diagram illustrates the relationship between these 4 functions of health system. Next slide. Let me remind about the timeline of the COVID pandemic, because it's, there is the impression that it's longer for many years, but it was started only at the end of 2019, when on December 31, the Chinese officials informed WHO about the cluster of the mysterious pneumonia in Wuhan. And since that time, passing through the many challenges, the disease is now defined in the 195 countries, reaching more than 3 million cases, including 230,000 cases of death as of the 1st of May 2020. So this is a very short period of time, which really influenced the situation with the health sector. The next slide. What was the factors which was mostly challenged the health system in general? The first one is necessity to make decision very fast and also to be very confident with the information you shared, including the necessity to have an early warning system which the society should or could trust. It is a very critical question. The second one is access to data. So the slogan, "Know your epidemics," is still remaining and is very important for any other disease. The COVID-19 showed that the globe lacks the ability to assemble a powerful health sector, especially intensive care capacity, and this is now a clear challenge for world leaders. The modern medicine became affordable and accessible easily without long registration procedure. Simultaneously, COVID showed how important to understand the whole spectrum of indication, contraindication of the medicine to avoid myths and misinformation. The crisis gave us an opportunity to address the social determinants of health and provide access to everyone in their own neighborhoods. The next slide. What lessons health sector from the epidemic? The first, that the effective communication is a key pillar of crisis governance. Being transparent and accurate in relaying information, preparing the public for what is coming next, and expressing a degree of empathy have ensured effective crisis communication. The second, adopting a whole-of-society approach is of particular importance in the crisis. Citizens were asked to actively participate in containment measures, including social distancing, self-quarantining, and community support for considerable yet unknown periods of time. And it's proof, it's work. And finally, implementing evidence-based strategies based on historical and current data is paramount, rather than acting based on what is politically expedient. Strategies rooted in validated evidence ensure the optimal use of resources and help to design probable scenarios. There are 5 critical areas of the health system which I focused on. The next slide. The 3 main areas for budget allocation reflect the following. First, the first strategy refers to using existing budgetary flexibility and exceptional procedure to fund first measures. The reprioritization through variants between line items or within budgetary programs envelopes was a first permitted actions to secure budget funding for immediate COVID response. The head of state or the finance minister have used emergency regulation to authorize urgent spending for an immediate response. And state budget flexibility allowed many countries to increase budget transfer to subnational levels and purchaser. And this is very similar what we had with the HIV epidemic in the beginning of the HIV. The second strategy was accelerating revision of finance law to secure a budget for the response through expenditure earmarking. The budget enactment process secure funding through expenditure earmarking with Fifa or budget spending. And this is very new for the finance ministers. And this is like something which we can use when we advocate for HIV and for the country response. From the budget formulation and structure perspective, supporting documents should be as robust as possible, and this is very similar what our donors is ask, especially the Global Fund. And some countries formulate budget by budgetary programs, which is very similar again for HIV, as many countries still keeping the special budgetary program for HIV. And the third strategy was essential for countries to explore ways to ensure public resources are made available to the front lines through timely and effective budget execution process. Softening expenditure was acceptable. Councils have been implementing countries introducing advance payment. Adoption of risk-based approach to control was another option. For example, pre-audit focused only on high-risk payments, while relatively less risky payments may be subjected to post-audit. So such evidence could be very well documented, and when we talk about the officials or activists, we can use it as a good example for promotion of the country response to any diseases. The next slide, please. So when we talk about the health standards or protocol, the speed of the updates was very fast. It was incredible fast. And for example, only during 2 months of Chinese epidemic outbreaks, 8 times. When we are looking for the European or the American evidence, they already made the online access to the guidelines, which is changed very smart way. Unfortunately, the level of recommendation was accepted as low. Inefficient data for effectiveness, intervention, and medicines is still presented, and there is like a critical leading role of WHO, while there is also the competition with some other countries. The next slide, please. So when we talk about the pharmaceuticals, I think we will have the more specific presentation later from one of our speakers, but I would like to focus on a lot of the potential of investigation therapies which are in many countries. We start to discuss the off-label use, including those drugs which are available for HIV treatment. The experimental intervention was introduced during within the treatment guidelines, and many countries start to record of the use of this medicine very strictly. So this is something new which we could learn and introduce to HIV as well. The next slide. For the procurement strategy, there was like 5 directions covering the policy with the centralizing procurement as a common piece of advice, improving coordination because nobody can tackle crisis by themselves, access to data, open, complete, and high quality data managed supply chain, and supply insight was the critical issue when we talk about the crisis response, while the civic monitoring and oversight is more important than ever because we are talking about the huge number of money and the procedures which happened within the system. The next slide. So when we talk about the information protection, this is like a new challenge for the many countries, and because this is like related to the issue of privacy. When the most people say privacy, they mean secret, and this is very similar to the HIV when we talk about confidentiality. And keeping secrets sounds like a thing you did with your elementary school friends, not like a constitutional protection. This thinking is obvious in times of crisis. The post-Soviet countries could share a historical perspective of privacy violation, and even in US in 1950s, the privacy rights were banned in response to McCarthy alarmism, exchanging privacy for security. Now, many leaders have proposed contact tracing programs, and contact tracing means identifying infected people and anyone with whom they have had contact, which is proven useful in fighting many diseases, including HIV. In the past, comprehensive tracking was labor intensive. And now there is like something new, like app-based version, which create new privacy concern. And so, from active privacy, the privacy means the right to act without interference. So I think there is like a new wave of discussion between the human rights activists and public health specialists, whether there is a borderline between the privacy, confidentiality, and public health approach. The next slide. Just to conclude, of course, the health sector very much impacted by this emergency and could be different changed. The HIV areas become more vulnerable because of necessity to compete with other health sectors, with other health area, and because the global resources would be reallocated totally. COVID-19 represents a significance. Every crisis also presents opportunities for sustained innovation and learning. How successfully this crisis is managed will depend on how well we are able to face and bring society together. Social systems are very much adaptive, and this crisis presents a learning opportunity for all of us. This is a test for governance system, and it is safe to say our collective response will shape the future for years to come. Thank you very much.
Thank you very much. Thank you very much, Volodymyr. Really great presentation, which set the scene for the entire webinar, given the framework of public health, how COVID-19 affecting public health, and also bring an opportunity for us. I would like to encourage participants to put questions to Volodymyr in the chat box. As I said, we will respond, each speaker will respond at the end of the webinar. Yes, just few highlights from my side. It's really important dilemma Volodymyr highlighted, public health or human rights. It's very important not to allow it be either or. It's important not to compromise on human rights, privacy, and dignity. And actually, civil society experience also might be used in this, even in some approaches like contact tracing. And another pick up from Vladimir's presentation. Never a health system experienced so much attention and so much resources brought to the health system. So it is an opportunity, of course, with the risk Vladimir also highlighted for draining resources from HIV in favor of COVID-19 response emergencies. At the same time, health received resources and attention. So big thing, because Vladimir also mentioned procurement and access to medicines. So I have a pleasure to introduce the next speaker, Fifa Rahman. She is a master in health law from Sydney University and PhD in international trade and intellectual property law from Leeds University. And she is also the Unitaid board member representing NGO, non-governmental organizations constituency. The topic is on access to HIV medicines and diagnostics, but you better introduce your topic yourself. Fifa, the floor is yours, please.
Thank you so much, Andre. And yes, I'll be speaking about lessons from COVID-19 in terms of intellectual property and what we can learn from HIV. So hopefully my slides will be up soon. And we'll start really with how a few lessons, and by no means is this an exclusive list, but basically, next slide, please. Yeah, the first is that what we're seeing from the response is what Volodymyr said earlier, which is speed trumps perfection, and the greatest error is not to move. It is true that we don't have complete evidence, but we're seeing that countries that react quickly above everything are doing much better than the countries who are waiting for absolute perfection. And as we can see, there are a number of countries in the West who have done this, and not necessarily waiting for perfection, but simply thinking that this is maybe a disease of the East and being complacent in certain areas. And I want to quote the example of Malaysia. Now, this is not an intellectual property example yet, but there are lessons for intellectual property. An example of Malaysia, where so far there have been only 105 deaths. So that's been updated in these couple of days since I've prepared the slide. There have been only 105 deaths. It's close in proximity to China. It receives a lot of Chinese tourism. It acted very quickly to build surge capacity. This phrase that Volodymyr also mentioned started building hospitals and renovating hospitals in February to increase ICU capacity, and started procuring diagnostics reagents in February itself. It also diversified its reliance on diagnostics and conducted contact tracing from the start. So there's a sense of urgency that we need to implement, not just in the health system's response, but also in intellectual property, which I'll raise again later. What we've also seen in terms of the second lesson in COVID-19 is that we've seen more examples of pharmaceutical profiteering. And this doesn't end just because it's in a global emergency. And the two examples that I want to give is remdesivir, where there's still very little evidence of treatment efficacy, but we've already seen via leaked stakeholder or shareholder documents that Gilead is already making sales on. And of course, when I talk about the fact that there's very little evidence so far, there's been one trial which shows no improved treatment outcomes, and there have been basically a bunch of different articles. So we don't know whether it's efficacious at all, but there's already money being made from it. The second example that I want to give is, of course, the gene expert machines and the cartridges. There is a campaign going on to reduce the prices to $5. But the situation is that these cartridges and these machines, which can be used for both HIV and TB and sexually transmitted infections and COVID-19, are approximately $20 per cartridge, and most countries can't afford this. So what do we do in the face of pharmaceutical industry profiteering? There are numerous intellectual property provisions that can be used to overcome these. And the third lesson is that budgets are shifting, and Volodymyr already mentioned this, and we need to be able to anticipate stockouts for HIV, and not just for HIV drugs, but also for TB drugs, as the largest killer of people living with HIV worldwide. And there's, the situation is changing. There's so much news coming out. So we need to really wait and see what's going to happen. But already there are rumored shifts in production in Indian companies. There are rumored active ingredient supply issues from China. So this is something that all of us as people working in the HIV and global health space have to keep an eye on. And the fourth one is central to my presentation today, that there's an increased global consensus on intellectual property solutions to increase access to medicines. And you can see this yesterday from the Pledge conference that was hosted by the European Commission, and President Macron was there, the Prince of Monaco was there, and everybody was saying sort of, you could really sense the sea change around intellectual property for medicines. And I'll talk more about this later, but Merkel said that we need all these medicines and diagnostics to be global public goods. What does that mean? Nobody knows at this stage, but I'll talk about it more in a little bit. Next slide, please. So what can we learn from intellectual property in terms of COVID? What we already saw is that AbbVie dropped its patent rights for Kaletra, but it didn't do this out of sort of the natural goodness of its heart, What you could see, and this is an article from the Financial Times, that Israel moved to issue a compulsory license because Kaletra, or lopinavir-ritonavir, was being used in the treatment of COVID. And it's only when or after Israel moved to issue that compulsory license that AbbVie dropped the patent rights. And we see many examples of where threats to issue compulsory licenses will precipitate a reaction from the pharmaceutical company itself. And we've also seen this in Malaysia, where the rumors and the cabinet decision had been made to issue a compulsory license or government use license for sofosbuvir. And what happened was, when the rumors went out, Gilead issued a voluntary license. So threats in this area are very effective in ensuring that drug prices go down and everyone gets generics. And I know this is very relevant for the dolutegravir discussion in Eastern Europe and Central Asia. The next thing I want to talk about is the Costa Rica proposal. So what is the Costa Rica proposal? It was a letter to Dr. Tedros of the WHO from the president or prime minister, I think it's the president of Costa Rica, saying that we needed a shared voluntary emergency technology pool for COVID technologies. And what does this mean? How does it work? I don't think that anybody sorted out the details yet, how a company is going to voluntarily put their rights in this pool and share it on a sort of open platform kind of basis. Do we know how that's going to happen? Not yet. But there's already a lot of political buy-in, as we saw from the pledge and Merkel saying that these need to be global public goods. There's a real sea change of how people are thinking about pharmaceutical profits. And there's a way to leverage on this for other diseases as well. Next slide. So what's Unitaid's role, and what does the Unitaid NGO delegation, which I lead, how does the NGO delegation support Unitaid's objectives? And of course, in the pledging conference, you saw that the chair of Unitaid, Marisol Touraine, was speaking, and Unitaid has, of course, officially, and that's another article from the Financial Times, officially supported the Costa Rica proposal and has a number of proposals internally that they are considering to work on a shared technology pool so that we can get access to COVID technologies. But what are the lessons for HIV, and what is Unitaid doing to deal with the HIV projects that it already has? So for COVID, what are the implications, basically, right? So Unitaid has a number of HIV projects, and what you're seeing now is that there's reprogramming of existing grants. So I'll give you two examples, although this is happening in a number of grants in Unitaid's portfolio. The first one is with the International Treatment Preparedness Coalition, where they said ITPC can use existing funding for access work on COVID. And there's also a project with KNCV, which is a project on TB adherence technologies. And there's already an exploration on how to use existing programming to use the TB adherence technologies to also work in COVID and trace people and make sure that people are getting both TB and COVID diagnostics. But this raises an important question. If there's a lot of reprioritization for COVID, what's the opportunity cost to HIV? And what's the opportunity cost to TB, which once again is the largest killer of people living with HIV. So there's a question about that. And Unitaid also is involved in the accelerator or the ACT in COVID-19, which is supposed to accelerate diagnostics and therapeutics. And Unitaid is officially supporting the Therapeutics and Diagnostics Partnership. But these are very early days. We don't know what the IP implications of these things are. Of course, there's a lot of political buy-in into some sense of a shared technology pool, but do we know what it looks like yet? We don't. And how do we support this? We support this when NGOs from all over the world come together and give myself and my colleague Rohit Malpani, who's an alternate board member, information about what's happening in their countries. So what we're doing right now is monitoring supply issues, for example, because countries are diverting money to COVID. We want to see whether there are stockouts of Kaletra, of dolutegravir, of raltegravir, of all these medications that are used in country. So we'd really appreciate hearing from NGOs on supply issues. And of course, there are a number of projects that are coming up at Unitaid that could require NGO input that could have global impact. Next slide, please. So what are the lessons? I've mentioned them several times already, and this is really in summary, to summarize my entire presentation, that threats to issue compulsory licenses really can result in companies dropping the patents or issuing voluntary licenses. And I gave the example of Coletra and the example of Sofosbuvir in Hep C, but that we know that there are movements in Eastern Europe and Central Asia to do this for dolutegravir, and given the political sea change in attitudes towards TRIPS flexibilities and access to affordable drugs, this might be just the opportune time to get these compulsory licenses and access to generics through the door. The negative point, so I know that Tanya mentioned what positive points we can learn, but it's also important to highlight that we could be facing some negative points, which are supply issues are likely to occur. And we've heard at least rumors that in Ukraine, for example, there are going to be delays. So there needs to be a strategic effort by NGOs to plot and anticipate supply issues and to act quickly. As mentioned in the start, that speed trumps perfection, but also to optimize existing resources, including gene expert platforms, and work on pricing reductions as the global campaign is going. Everybody wants a $5 cartridge for Cephei gene expert products, but also to diversify supply. The countries like Malaysia did well because they procured from a number of different countries in terms of COVID. So we need to ensure that there's a diversification of supply of medicines and diagnostics in HIV as well. And generics is, I'm running out of time, so the generics is an obvious point, I think. And I've mentioned the compulsory licensing for dolutegravir, but also raltegravir. I'm not sure how prevalent it is used in Eastern Europe and Central Asia, but it's very expensive in Southeast Asia, and there's value of going for generics as well if they're available. I am out of time. I hope you enjoyed the talk, and I look forward to listening to your questions and answering them. Thanks very much.
Thank you very much, Fifa. Amazing presentation, really great points, both in terms of the challenges we have to keep attention, like supply risk and supply interruption. And also the points you highlighted about the movement in reducing patent pressure, in making medicines more available or dropping prices down, like with gene experts, are really, really critical. I just recognize that, well, we don't have any information about the Global Fund, the major donor for the region. And just few words, maybe in my different capacity, board member for developing country NGO delegation to the Global Fund. Global Fund allocated up to $1 billion to address COVID challenges. 500 million among them through reprogramming of the current grants already awarded to the countries, and another 500 millions through newly established mechanism called C19RM, COVID-19 response mechanism. On the Global Fund website, you can find the announcement, call for proposal, and it's open. It includes also civil society and human rights priorities as well, not only PPE, procurement of personal protective equipment, but has much broader agenda. Just decided to mention it as well. while inviting our third speaker, Anton Basenko, expert on drug policy, human rights, gender, and communities at Alliance for Public Health, also member of CCM on behalf of key vulnerable communities in Ukraine, and focal point for Global Pitch project. Anton, the floor is yours, please.
Yeah, thank you, Andrei. First of all, I'd like to propose to land from more global issues to our regional reality, and everything I'm going to speak about in my presentation is a part of my personal experience, challenges and successes, because I represent the community of people who use drugs and I live with HIV. So you will see the list of services which were introduced or catalyzed in the region of Eastern Europe and Central Asia, specifically in time of COVID, and now we see that it's simplifying and making them really sustainable. I propose to start from basics. We all know that the main component of the harm reduction is needle and syringe programs. Slide, please. And yes, this one. Thanks. And this is excellent entering point in the cascade for people who inject drugs or even the people who use drugs. And according to the recent Lancet publication, we know that now people who use drugs is considered as a key affected community for COVID-19, not because they live with HIV, but just as such, because of the low immune status, comorbidities, alcohol use disorders additionally. So harm reduction 2.0, why it is called 2.0? Because COVID reality made us really reconsider the traditional approaches, not only how we provide services, but what we distribute and how much and how many. In majority of Eastern Europe, Central Asia countries, the volume of harm reduction supplies increased for the period of 1 week to 1 month, for example. It's not only the increase of the number of different supplies, but also we see the good examples of packing the different kits like safe boxes or helpers for different key populations where there are packed different supplies. And also here we are mentioning the ways of distribution of these supplies. For example, distribution by mail, couriers, or so-called stash points. The increased number for me, the increased number of supplies for me personally is really good example, because my personal concern was always why 200 syringes, for example, recommended per year by WHO. So for me, it was always the question why it's not 365 at least syringes, right? Like 1 syringe per day. Yeah, so now we see that increase it's impossible, and it really makes more attractive the program for key populations. Next slide, please. Next slide. Thank you. So, syringe dispensing machines. It's actually really good follow-up intervention of previous point, because major of courier or outreach approaches, you need human resources. Here we are talking just about electronic machines, discrete electronic machines, which provide sterile injecting equipment or other kinds of supplies, including tests or condoms. These products are provided free at low cost. Advantages are increased access and reach, including geographical reach. 24-hour accessibility, and of course it may attract people who inject drugs or use drugs, and not only them, depends on the supplies you put in these machines. Reduced overhead costs and client anonymity. Of course, it's quite new for our region, but it's absolutely evidence-based, well known in Western Europe, US, or Canada, so we definitely should include it in our practice. Next slide, please. Online consultation. COVID reality made us really increase and use different approaches of online consultation, whether it's telephone, social networks, email. It became the major method of work with the beneficiaries. We have the good examples from North Macedonia, where the need in online counseling increased by 70%. In Georgia, more than 700 consultations are provided online. We have good example from Ukraine, where the national hotline on OST and drug use, during the first 2 weeks, we observed 50% increased number of calls. And of course, distant counseling significantly increased with a view to limitation of transportation, readdressing. Also, as a connection with psychologists and psychiatrists is ensured in particular, but not limited. It's an example from Romania. Next slide, please. HIV self-testing. For most of you, it's not new as such, but it was still really limited approach by different reasons, and now because of this COVID reality, we see the increase of self-testing use. It's fully functional in Kazakhstan, in Georgia. Minimum 150 clients in each of the countries received saliva tests ordered by them. And also, as I previously mentioned regarding syringe dispensing machines, so wide-scale introduction of test dispensing machines can also contribute to increase the number of HIV self-tests. Next slide. Antiretroviral therapy by mail. Yes, it's possible. Now we know that it's possible. Cost-effective service. Good example from Ukraine, where Ukrainian network 100% Life organized delivery of antiretrovirals to HIV-positive patients by mail in 6 regions of one of the projects. Next, please. Next slide. Yeah. Mail is not the only way of delivery. You will see here the different examples of delivery with a courier, like this, for example, in a practice used by majority of countries for quite time. However, it became very important under the conditions stipulated by the COVID-19. Here you can see examples from Moldova, Russia. Also talking about the volume of antiretroviral therapy which is provided, because earlier the drugs were given, depends on the countries, for 1 month or 3 months. But now this period extended in some countries for 3 months, like Kyrgyzstan, in Ukraine 4 till 6 months. We have examples from then in some regions up to 9 months. It's provided. This approach is used not only for ARV but also for TB drugs, which are now distributed for the period at least 2 weeks in Kyrgyzstan, Ukraine, or Georgia. It's the same with hepatitis C treatment. And within these conditions, the need in ARV delivery to home increased by 70% in Georgia, for example, and by 50% in North Macedonia. Example from Kazakhstan, that in all the regions, ARV delivery to home is ensured for those who need it. because there are huge, it's a big country and huge transportation limitations now. As regards to the patients who faced lack of drugs and are not at home but in another city or region, the online service of temporary registration in the current place of residence is also available. Next, please. And from my point of view, one of the best examples how specific challenging environment or specific periods, like period of time like quarantine or lockdowns, can catalyze the really success stories, which is take-home opioid substitution therapy. After the beginning of the pandemic and quarantine, OST became available for taking home for the different period of time from 5 to 14 days in some Eastern Europe, Central Asia countries. So in some countries where it was available, but for smallest number of days, the number of days increased. For some countries, it was absolutely new approach, and it started. So, for example, Moldova and Estonia.
Sorry, Anton, sorry. Your voice is breaking. Maybe you can just talk through the mic.
Is it okay now?
Yeah, it's better now. Yeah.
Oh, okay. Sorry, maybe because the headsets in my hands is in Moldova or Estonia, where it was available for 2 to 4 days, in Kyrgyzstan up to 5 days, Poland and Romania up to 14 days, Georgia and Lithuania up to 5 to 7 days. So in Moldova and Ukraine, the opportunity of taking substitution therapy home existed before COVID-19, but it was really catalyzer of the increase of the number of patients who have access to substitution therapy for take home. And let's take Ukraine as example. For example, as of the 1st of April this year, we have almost 13,000 substitution therapy patients in Ukraine. Before COVID-19, about 50% of them were allowed OST take-home doses for the period of up to 10 days. By the end of April, in the quarantine reality, 19% of the patients received the OST for the period 10 to 15 days. And we even have one regional example where we have 30 days provision. All the patients are provided with the distant counseling, whether it's Skype, Viber, Telegram, or Facebook. The OST sites optimized working hours, and we have quite interesting examples in terms of the transportation limitations, specific issuing of travel tickets or badges for the substitution therapy patients which have to visit their clinics, whether it's every day or one time in 10 days. Next, please. And here we're coming to conclusions. Definitely distribution of take-home opioid substitution drugs for a period of at least 14 days should be provided. It's 2 weeks. Distribution of harm reduction supplies, and also I forgot to mention that we are talking not only about traditional supplies like syringes, condoms, spirit wipes, or lubricants, but also example like disinfectants, because we know that some organizations started to procure masks, gloves, disinfectant, and specific supplies for prevention of COVID-19. And in terms of the street way of life for some number of clients or people who use drugs, for example, I think the disinfectants will be quite good part of the kits or the list of supplies which are provided. And the distribution should be provided for up to 1 month. Delivery of supplies to clients of harm reduction program, mail and courier service. Introduction to the practice and popularization of test or syringe dispensing machines. And I would like to remind our partners from the region that now it's a good window of the opportunity if you are developing new proposal from your country to the global fund and you are going to submit it. I think it's really a good opportunity to put such an idea because it's really evidence-based thing. We definitely need the increase of online consulting services, telephone, social networks, messengers, and different kinds of hotlines. Of course, we are not excluding the face-to-face consultation, but we understand the clear advantages of the online services. Expansion of self-testing, delivery of antiretroviral therapy drugs for up to 3 months and more depending on countries. Delivery of ARV by mail, especially if it's impossible for the patient to come and receive drugs in a medical facility. And of course, the possibility of temporary registration and receiving antiretroviral therapy at the place of residence. So I'm looking forward to your questions and hope that we all will keep in and develop these successes because the COVID-19 lessons give us the real window of opportunities as well as for non-governmental organizations, as well for key affected communities. Thank you very much.
Fortunately, we faced some technical challenges. Your voice was breaking, so not everyone heard maybe everything. So just to highlight that presentations will be available, and also from my side, just would like to highlight one example on substitution therapy. It's really amazing results that in Ukraine we have nearly 90%, 90 patients now on take-home dosages. Nobody could dream about this before the COVID. So this is an example how this COVID situation actually change things for the better, in a sense, for more convenient access for patients. And thank you for Anton for a number of examples, not only from Ukraine, but from other countries of the region, showing how we can progress even in these challenging times. So I would like to move forward and introduce our next speaker, Niamh Eastwood from UK, London. Niamh is Executive Director of the Release, the British Centre of Expertise on Drugs and Drugs Law. Niamh, please be aware that we have simultaneous translation, so please don't speak so fast, and indicate when technicians should move the slides. Niamh, the floor is yours.
To speak this morning. Sorry?
No, go ahead. Thank you. Yeah, please go ahead.
Thank you, Andrea. So as Andrea says, I'm Executive Director of Release. We are a NGO working in the UK providing legal services to people who use drugs, and we campaign for reform of the drug laws. And I've been asked today to talk about what are the opportunities for reform, drug policy reform, in the context of COVID-19 and post-COVID-19. So if you like, a little bit of a kind of looking into the future and to see what arguments that we can use and what policy approaches that can be applied in order to support reform. And Anton very well highlighted in his presentation the silver lining that we're seeing in terms of harm reduction approaches in terms of COVID-19. I think there is wide recognition that people who use drugs and who are dependent on drugs are a very high risk population when it comes to COVID-19. If they contract the virus, then the health outcomes for them can be very poor. And so many governments, including the government in the UK, have taken steps to ensure that this population is supported and that there is reduced social interaction. And so, as Anton highlighted, we've seen a move from people being on daily supervised consumption of methadone and other opiate substitution therapies, moving to weekly or fortnightly scripts. And I think this balance of public health protection is really important as we move forward into how we can push for reforms in the current climate and post the COVID crisis that we're experiencing at the moment. Next slide, please. Next slide, please. So what I want to sort of explore today is decriminalization, so the ending of criminal sanctions for possession offences, decarceration, the release of prisoners, and the reduced imprisonment of people who use drugs and people who are involved in low-level activities within the drug market. And then just to go through some of the work that my organisation's been doing in light of COVID-19 and the opportunity that we've had to work with various stakeholders to protect the well-being of people who use drugs, particularly those who are dependent on drugs. Next slide, please. So decriminalization, as I've said, is the ending of criminal sanctions, largely for possession offences, but can apply to other low-level drug-related activity. In partnership with the International Drug Policy Consortium, Release, through our website Talking Drugs, produced an interactive map at the start of the year that highlights all of the jurisdictions across the globe that have adopted a decriminalized approach to drug possession. The map itself is hosted on our multimedia website Talking Drugs. This is a site that reports on daily updates on drug policy across the globe and harm reduction initiatives that are being developed within countries and via our partners across the world. The site is in 8 languages, including Russia. The map itself shows 29 countries that have adopted a non-criminal justice response to the possession of drugs, and 49 jurisdictions, so that is largely US states and Australian states, that have decriminalized some drugs, mainly cannabis. I'm not going to get into the technical details of decriminalization, but I'm very happy to pick that up in the questions and answers. But I'm thinking more about what are the sort of policy prisms that we can push for reform through. Clearly, we are in a public health crisis. And we have seen, as others who have presented this morning, a real galvanization of a public health response. And the use of law enforcement in this current crisis in most countries has been subservient to the public health bodies and the public health approaches adopted by government. And so is this an opportunity for us, therefore, to push for a more public health and less law enforcement approach within drug policy? The other aspect that I don't think we've talked about yet is the economic fallout of COVID-19. We are clearly are experiencing and are going to continue to experience an economic crisis that, like the likes of which we have not seen since the 1920s and possibly before. So focusing on the ideas of public health and the economic arguments, how can we promote a decriminalized approach within countries as we move through this crisis and post this crisis? And I think if we look at the evidence from other countries across the world, most notably Portugal and Australia in terms of its decriminalization of cannabis, and also its diversion program that is operating in all states where people who are caught in possession of drugs are diverted away from the criminal justice system. In that context, we have research that clearly shows us that where someone is diverted away, they have improved physical and mental health outcomes. I think when we're seeing that public health is trumping sort of punitive approaches across the world, this is something that we can continue to advocate for during and post this crisis. A good example of this was the UN Committee on Economic, Social and Cultural Rights, when commenting on Ukraine's criminalization of people who use drugs through possession offences. They very much highlighted that this was a barrier to accessing services, including HIV and drug treatment services. So I think we can continue with these arguments as we move through the coming months and the next year or two. The economic argument, as I've said, is going to be fundamental to the work that we do. I think many of us who work in this field come to it from a social justice perspective, but we also realize that political arguments are often underpinned by the economic ones. And we will no doubtedly see a pressure on state resources like we have never seen before. And so, again, using evidence that already comes from those jurisdictions that have decriminalized drug possession, I think we can adopt some of that research to again push for reforms. So we have, again, from Australia, but from some of the European countries such as Spain and Italy and Portugal and the Czech Republic, evidence that decriminalization reduces the burden on police resources and on wider state resources. Research from Portugal has found that in the first 10 years of implementation of decriminalization, there was an 18% saving in social costs. And that was not just savings to police, but wider savings to the state in terms of court time, prosecutors' time, and also the fact that people who were not criminalized could continue to participate in the economic market, in the job market, and therefore could contribute through taxes. Next slide, please. Another phenomenon that we are seeing at the moment, which is, I think, probably limited to in a meaningful way to two continents at the moment, and that's Asia and in some African countries. But it is the tale of decarceration, the mass release of prisoners across, sorry, previous slide, please. The mass release of prisoners across that continent. Myanmar, for example, in the middle of April announced that it would release 25,000 prisoners due to the crisis. And that is a quarter of Myanmar's prison population. These are huge numbers. The level of releases that we are seeing is unprecedented. But it does seem that this is largely an experience that is occurring within, as I've said, Asia and to some degree, some African countries and one or two Latin American countries. Whereas in Europe, the numbers are tiny in comparison. Italy, for example, over April only have released 50 prisoners. In the UK, the Minister of Justice announced that 4,000 people would be released from prisons in the first week of April. As of this week, 33 prisoners have been released. And the UK, like many other countries, suffers from prison overcrowding. We have high rates of COVID being transmitted amongst prisoners. And so again, arguments that we can use to push for decarceration, and particularly decarceration of people who are imprisoned for drug offences and for low-level drug offending, is one that we could focus on the experience of these countries and use those experiences moving forward, use the opportunity to convince countries in the global north and in Western Europe and in Eastern Europe to take bolder steps in terms of releasing those who are incarcerated for low-level offending. And this is important because when we look at the numbers of people, the percentage of people who are convicted for drug possession offences globally, it is an estimated 83% of people who are convicted for possession only. So the COVID crisis over the next 18 months gives us an opportunity to assess the impact of decarceration in other countries and to use those examples as a basis for promotion of reform in our own jurisdictions. Next slide, please. Next slide, please. Finally, I just want to sort of highlight some of the work that we have done to respond to the crisis within the UK, but also to support our partners across the globe through the work that we do on talking drugs, and to share insights and knowledge of what's happening in light of COVID-19 and how that's impacting on the drugs market. One of the first things that we did was to set up a network across the UK of people who are close to the ground, who work directly with drug users, who are activists themselves, to really monitor what's happening in the market within the UK. Obviously, the drugs market in the UK does not operate in silo. It is dependent on drugs being imported and on trade routes coming up from Afghanistan and from Latin America and other parts of the world. And so again, we're working with partners across Europe to develop similar surveys, but also partners who are experts in producer countries to monitor what's happening there. And again, in the questions, I'm very happy to talk about some of the outcomes from that work. One of the things that we're particularly concerned about is that the UK was already suffering a public health crisis in terms of drug-related deaths, where the numbers of deaths were at a record high for the 7th year in a row, and where the UK accounts for 1 in 3 drug-related deaths in Europe. Now, that is largely driven by heroin. One of our concerns is that if fentanyl comes onto the market in the UK, it will have a catastrophic effect in terms of the health of people who use drugs and the risk of death to them. Glasgow in Scotland, for example, has one of the highest rates of drug-related deaths in the world. It is comparable to the US and to Canada. So as I've said, if fentanyl or other synthetic opioids come into the market, there are real problems ahead. So we're trying to monitor that at the moment through this national network, but also through a public survey. The public survey has got ethical approval from the Manchester University and is being supported by academics. We have also separately produced resources for people who use drugs. So we produced an essential journey card. One of the concerns that we have is this is often a population who are highly are subject to high levels of law enforcement. They are known to law enforcement, and we were concerned that if they were going to pick up their OST or their harm reduction equipment, they could be unlawfully detained. And so we produced cards to emphasize that these were essential journeys. We have also highlighted harm reduction messaging by publishing the work of the International Network of People Who Use Drugs. That's been published in 10 languages on talking drugs. And we're obviously lobbying government to try and push for more funds for drug treatment and for harm reduction services in the UK. So that's the work that we've been doing. Thank you very much, and I look forward to your questions.
Thank you very much, Niamh. Amazing presentation and amazing work you are doing with the release. I am so impressed with the figures, with the numbers you gave from Southeast Asia, even from the countries like Philippines, being the red flag in incarceration and drug use policy. So this is really inspirational for us how we can take it on board in our context, Eastern Europe and Central Asia, or broader in Europe, where the progress is not so much. And for me, it's a signal that actually, as amnesty came, there was no sense to criminalize these people for drug possession for personal use. So it's also a strategic lesson. So really thank you for both all parts of your presentations, including observation what's in UK and work you are doing. Dear colleagues, we have actually questions for everyone. So let me start. I have 3 questions for Volodymyr. Let me read it all 3, and then you can answer. So first question, after restrictive measures like lockdown, some governments may choose to impose health dictatorship. How can we protect our liberties? The second question, in EECA, medical doctors are key vulnerable group to COVID-19. What are the core 3 steps you recommend to take to alter this? And final question, why some countries reacted quicker to COVID-19 than others? Why those responses were so different? So, Volodymyr, please, address, these are kind of big questions, but address it, please, to the extent you can. Yeah, thanks.
Thank you very much. Maybe my colleagues would like to add something at the end, but when we talk about the health dictatorship, I would argue that there is no like specific health dictatorship. There is like a dictatorship per se. So if we will have some dictatorship in the health, that means it will immediately transfer to other areas of our common life. And this is exactly what the activists should concern the government, and I think there is like a very common actions should be taken. The first one is to document any type of the violation or human rights violation. Either it happened in health sectors or in the other areas. The second one, for example, for the personal data protection, it would be good to conduct independent security risk assessment when we are talking about the applications the police will be used or the health authority will be used for tracing the contact or something like that. Of course, the sharing of information is the most important issue and most powerful issue at this stage, especially using the social media and the networking which already exist in the country. And I think COVID doesn't deploy this approach and these options. And of course, to provide the personal assistance to the special assistant to personal cases about the human rights violation, which could be through this new approach between the privacy and the public health approach. Regarding so it's like for the first question, and if somebody want to add, it would be for the second question regarding the medical doctors. I would refer that they're not only in the EECA countries, but also in many countries of the world. The medical professionals are in the front line of the COVID combat, and that's why they are considered as the vulnerable population. The 3 steps is which we could elaborate. The first one, the introduction of strict infection control, either in the medical facilities or in the ambulance or family doctors, which include the availability of personal protective equipment. For example, in Ukraine, we do have a lot of cases of the doctor's infection, not in the specific hospitals, but exactly hospital was not nominated as a special one. And this is, first of all, because of lack of the PPE. The second one is the introduction of clear hospital triage, which means the defining the patient with the symptoms and separated them from other. And the third one is the administrative measure of infection control, especially, for example, the timeline or time hours for working in the infection areas, and strictly like control and oversight of this situation, because when the physician are working more than 4 hours in these infection areas using the PPE, they immediately start to make the human errors, which mean the touching the faces or the not using the PPE correctly. The second step is the access to testing for the medical staff, because they do have the more risk, and this is very similar to HIV. Like test those who are at the most risk for the infection. And probably HIV could share the experience from the when we talk about the yield testing yield and the options. And the third one is provide support and the motivation to the medical staff, because they are really suffering. And this is not only financial one, but also the moral, and they provide the empathy for them. This will serve as a good steps for protecting medical staff. And regarding the last question, it's very interesting question issue why some countries is doing quicker, and it depends on the historical perspective, but also from the political approach which used in the country. Because if the country are real promote democracy, that means that every step should be discussed with the society properly. And this, of course, requires some additional times, and that's why it's like imagine that the country is not respond quicker. But at the same time, when every steps are done openly, transparently, and in the discussion with the society, the long-term perspective are much, much better than the introduction of the real lockdown without the explanation what happened, why they did it. So I think that there is the main important issue is the development of trust between the authority and society. And if trust exists, the long-term perspective will be much, much better than in the populistic environment where the government made the decision without any investigation of society, thoughts, and this creates a lot of misinformation and myths. So it's a complex issue which is on the political agenda, and I think we will live with this in the next few years, developing the new global security and the new health system security.
Comprehensive answers. Thank you. So let's move to the next set of questions. I have two questions for FIFA. Number one, global procurement mechanisms have not been strong to deal with COVID-19 emergency. Do you think there is a case for setting up an emergency procurement mechanism for essential drugs? Who should lead on this? And the second question, how can you make your government start working on compulsory license? How you made it in Malaysia? Which arguments you used? Please, FIFA, the floor is yours.
Thank you so much, Andre. So on the global procurement question for COVID-19, the procurement systems globally were not working perfectly for HIV, TB, and malaria already. For example, there was a stock out of pediatric lopinavir, ritonavir in Mozambique last year. There were stockouts for TB drugs in Mumbai. There were stockouts in Eastern Europe and Central Asia. So short answer is yes for COVID-19, but also yes for HIV, TB, malaria. We need a coordinated, comprehensive discussion on procurement for all essential drugs and not just for COVID-19, but especially now because funds are going to be diverted away from other diseases. So it's especially necessary. I personally think the WHO should lead, but that all the global procurement, the agencies that procure should be in the room. We as the NGO delegation at Unitaid have been asking for a procurement discussion with all the agencies for about 2 years now, but I think there needs to be more pressure from the outside. So if there's pressure from Eastern European NGOs to these global health agencies, you guys need to sit down in the same room and start talking procurement for all of these medications. I think if there's enough of that pressure, maybe that it will move the WHO to get UNICEF, Global Fund, everybody in the room that's necessary. The third question was about how to make your government issue a compulsory license. And I know this is a critical question for many Eastern European countries who are considering dolutegravir. And I was lucky enough to visit 2 Eastern European countries and speak to governments in terms of what should be done. But in Malaysia, it was a number of factors that fell into place quite well. And the first was the fact that Malaysia had issued a compulsory license for HIV drugs before. So they were experienced, they knew the threats they could receive, and they knew that they knew what arguments that needed to be made. Secondly, there was a DNDi feasibility trial for ravidasvir, which is a Hep C drug, going on. And it helped that DNDi experts were speaking to the Minister of Health, were speaking to the Director General of Health. And at the same time, there was a coordinated effort by NGOs. And this existed at the same time where the Ministry of Health budget for purchasing of medicines was cut. So all these factors came together, and the government basically said, look, our health budget has been cut. We can't afford it. And also your reasoning for the price for sofosbuvir for Malaysia, that Malaysia is in between Hong Kong and Brazil, so the price should be arbitrarily set at this price. All these factors came together. So, what can be used for Eastern Europe and Central Asia? And I'm not just speaking about DTG, but also Kaletra, that we need to take advantage of these situations. But I appreciate that. I mean, the situation that there's a sea change in philosophies on intellectual property and access to medicines. Angela Merkel is saying we need medicines to be a global public good. So, I think there needs to be immediate sensitization. And I know that just based on the 2 countries I visited, that there's a lot of policymakers that need to be sensitized. But there is a really ripe environment for the idea that these medicines need to be cheaper, and we need to take advantage of that and sensitize our policymakers that some of the most powerful countries in the world are saying that we need technology pools and intellectual property solutions to drug prices. Thanks.
Thank you, FIFA. Yeah, great. Yeah, thank you for your answers. So, moving to Anton, we have three, but actually fourth question also came. So let me read it for you. The first, why the progress on OST in Ukraine is so strong compared to the rest of EECA region? The second question, what can community do to preserve these simple modalities you suggested in your presentation? Can you advocate for it in your role in Global Fund Board? Can you advocate for this in I Do It guidance through input? Third question, what are negative impact to harm reduction programs and communities? How can you evaluate access to services? Is it increased or decreased? Human rights issues with question marks. And there is a specific question I'll read from the phone perhaps from Odessa. In the time of the quarantine, it's in Russian. In the time of the quarantine, it's not possible to enroll new patients on IST because the only narcolog, drug treatment specialist, the only one in Odessa who provides these necessary papers in the form F11 doesn't work. So it is a specific question, but maybe to answer it in a broader context, are you aware about recruitment on new patients in the time of COVID? Thanks, Anton. The floor is yours.
Yeah, actually, it's not 4 questions, it's almost 7 questions I counted, but I'm really pleased to have so much attention to topic I presented. So let's start from the very beginning. So why the progress on OST in Ukraine is so strong compared to the rest of the region? Everything is very simple. Ukraine, as well as the other countries of the region, have the same post-Soviet heritage, have really similar legal or social economic systems, and we started substitution therapy even later or at the same time with the other countries of the region. But now, as of today, and even the last years, we have the biggest substitution therapy program in the region, 13,000 of patients, and this number is still increasing. Of course, we are always trying to compare with something better, with some kind of best or success stories, to have some goal for other countries. And the fact that take-home dosages were available for more than half of patients, every second patient had take-home methadone or buprenorphine even before quarantine. So we have quite well involved community in the development of the quality of substitution therapy, and quite positively changed legal framework, which we are sharing with the other countries as our expertise. What can community do to preserve these simple moralities? As usual, proactive advocacy and some kind of official appeals, and using different advocacy mechanisms, whether it's formal or informal, because we are talking a lot in social networks. We are raising oral concerns about the whole range of different problems we are facing as a communities. But for changes to reach the advocacy goals, it should be practical steps. If you have justification from your practical work that these modalities are working, just bring this justification and be proactively involved in the changes of policies or legal acts through available mechanisms like CCM or intersectional working groups under the different ministries, etc. So nothing new. Yes, I can advocate this in my Global Fund Board delegation member role, but we should be really clear about the level of the decision making of the board. Of course, we are trying to bring country examples, community examples to the level of the board or the delegations. And of course, we can use the capacity of Global Fund in our advocacy, but it's rather more political influence or financial influence, and it's not canceling our internal country-specific advocacy, which should be done or has to be done by the community's leaders. Of course, we can advocate this in I Do It guidance with input, but thanks input, they from the very first days of the global pandemic, they already published specific kind of position paper or recommendations what should be done, specifically done, or specific support which is needed for people who use drugs in COVID-19 time, and take-home dosages on OST, for example, were there. I think for future, we definitely can develop some specific part of I Do It, touching some kind of challenging operating environment or specific urgent or emergency situations, or just additional position paper specifically about these topics. Of course, we observe as well as positive as well as negative impact on harm reduction programs. Positive, which were raised in my presentation regarding the approaches and services which are provided, but negative impact is also natural, because people who use drugs or other communities with for example, from low-income communities, low-income countries, facing this list of limitations, transportation limitation, and talking about people who use drugs, for example, the drug scene is changing. Empty streets, you are really visible for policemen or for the environment. So all these things, all these challenges, making more difficult your access to harm reduction. And here is a question about human rights issues. Actually, quarantine and lockdown limitations are the human rights issues as such. I mean, talking about the limitation of freedom of your movement, or limitation, for example, I mean, the physical limitation in access to medical services as a result of the lockdown. Everything is around human rights. But also we have a particular example about gender-based violence, which is increased in the pandemic times. So the last point about the Odessa, which is brought from Odessa, but it's about generally involving the new patients into OST. I know, first of all, I know this Odessa example very well. It's a really specific situation in Odessa, because just imagine it's only one narcologist, one doctor, which is allowed to in your diagnosis, which is kind of basic legal requirement to start substitution therapy. So if this person is out of office or on holidays or wherever, you are stuck. But for other cities or regions in Ukraine, we faced different situations. Of course, first weeks and days of the quarantine, because there were a list of recommendations from Ministry of Health, including the avoiding the crowds of people in substitution therapy sites, and changing the working hours or working days specifically to avoid this hyperpopulation in these premises. It made the number of new decrease, because we understand that for the induction or introduction of substitution therapy medications, at least 2 weeks you should be under the daily observation of the doctor. But still we have, so for example, Kiev city, there were particular pause, like a standby in the involving of new patients, but now this process is started, and other regions are doing this as well. I think they are just fitting or matching this technically with the reality of epidemic limitations, but it's available. And I think for Odessa, we just need additional push, because we were there with the Ministry of Health monitoring visit, but I see that very small things are changed. Thank you.
Thank you, Anton. Thank you for these questions and some practical suggestions, and particularly on Odessa case, we can also follow up offline, with more specific steps. So moving to questions to Niamh. So there are two, but also additional one arrived as well. So 3 in total. First question, changing drug laws is always difficult. Sometimes it's easier to change police practices and create good precedents. Malaysia has death penalty for drug use, but doesn't enforce it. Should we rather work with the police practices than try to revise drug legislation? This is the first question. Second is kind of strategic. Yeah, why drug issues are so political? How can we depolitize them and leave to medical workers? And the third question, in Russia, on the contrary, criminalization for the disease is gaining momentum. This is clearly a vector not in the direction of human rights. Punishment for violation of quarantine measures and self-isolation, medical mistakes made in a matter of days are already being applied. What can we do at the international level to call on states to reduce their punitive function against their own citizens? So that's 3 questions for you, Niamh. Please, the floor is yours.
Thank you, and those are really interesting questions. In terms of the first question and the you working with police as a way to reform drug laws in a practical application of them, I think that's, you know, build your sort of cohort of supporters wherever you can, whether that's political or law enforcement. It really depends on the jurisdiction as to whether it will have impact on practice. So I think from work that we have done, where you have a national police force, it tends to have less agility to determine a policy around how it will implement those laws, if that's right, if that makes sense. National police forces tend to be beholden to the Interior Minister and are much less able to have flexibility in terms of the application of the law. I think what we've seen is in countries that have more devolved police jurisdictions, so at a local state level, there tends to be that flexibility in terms of how to implement the laws and whether they can themselves pursue a mechanism or a policy that seeks to divert people away from the criminal justice system. So what I would say is, yes, police are useful advocates, but if you're looking for real change and reform, then you have to see what ability do they have to do that work within their jurisdiction. And 2 examples that I can give is, for example, in Canada, we have state level policing, and we've seen in Vancouver, for example, a really progressive policing approach to drugs, both in terms of diverting people away from the criminal justice system, but also supporting safe supply initiatives. So many people will be aware of the recent implementation of prescribing of hydromorph through vending machines in Vancouver. That was supported, and implementation of that policy was underpinned by law enforcement support, and there are really progressive police officers in Vancouver who are able to do that work. In the UK, we have 5 police forces that have implemented diversion programs, and that means when someone is caught in possession of drugs on the street, they are diverted into a short Saturday morning course. I'm not sure, do you guys have speeding awareness courses in your country, where you go along if you've been caught speeding and you get a slight education program on how not to speed? It's very similar to that. It doesn't result in a criminal record. So there's where you can see actual reform in practice. And then we can use those reforms to build the advocacy for national reform. We can use the evidence from these local schemes to feed into the national advocacy approach. I think working with colleagues in African countries, some of them work at a national police level, like in Uganda. So they have a chief and superintendent there who's very progressive on drug policy reform and harm reduction, but he's limited in what he can do practically, but he's an advocate. So yes, work with police where you can. In terms of the second question and the politicized nature of drug policy reform, I think historically, there's been 2 main drivers for why politicians don't want to touch this issue. The first is that it is not seen as politically exempt to do so. They are not willing to spend the political capital on it. In the UK, we call this a third rail issue. So it's just not important enough to invest in terms of, you know, making sure that you get votes at the next election. The other is that for governments, I would argue that for many of them, and this would include Russia as we move on to that question later, is that it is a useful way of othering people in society, dehumanizing them, and then blaming them for the problems that local communities face. So that in local communities, it's the heroin users, it's the heroin dealers who make your local environment sort of less than normal, and you know, it's their fault that there is crime and all the things, rather than actually the government's fault around lack of investment in those communities. So it's a very easy tool for governments to blame this group of people, and we see it with other groups, refugees, for example, and in some countries, you know, the LGBTIQA community. Although I think that's changed. I think this issue is gaining political support across the spectrum. I think if we return to Malaysia, the very sort of driver for the discussions around reform in that country was the case of Luqman, a man who had been sentenced to death for supplying medical cannabis. That caused huge public outcry and started the conversation at a political level of the need to reform drug policy in Malaysia, with both a commitment around ending the death penalty, although I'm afraid that commitment seems to have waned slightly, but also a commitment to explore decriminalization. So these kind of cases can be catalysts for reform. And also I think that we've seen this become a much more it's gone up the political agenda over the last 3 or 4 years. I would say that even longer actually, maybe 8 years. I would say the work of organizations like the Global Commission on Policy has really provided a legitimacy in this area. The fact that we now have the INCB describing Portugal as the best example of a drug policy globally is something we wouldn't have thought could happen 15 years ago. So I think we're seeing a much more fluid move towards political support for reform. So I'm positive about the future in this area. I would not leave it to medical workers. 90% of people who use drugs use recreationally. They don't need any interference from the state bar from harm reduction advice and interventions if they require them. And there is also always a risk that a medical system can become as controlling as a criminal justice system. So yes, we need medical interventions when a person needs and wants them, but only in those circumstances, not as a replacement for criminal justice surveillance. And finally, Russia, the problem of Russia. I think all we can do in this area is continue to highlight the human rights abuses that are going on within country. We know that Russia has a very poor drug policy that has contributed to some of the highest rates of HIV transmission in the world, driven by injecting drug use. They do have decriminalization, but the thresholds are so low that it is a hollow system. It does not work in practice. And anyone who is caught above the threshold faces 3 to 10 years in prison. We have our colleagues at the Andrei Reklov Foundation who have just had to close down a lot of their website because of the narco propaganda laws in Russia. It's a really tough environment, as it is in other similar countries where we have strongmen dictators such as the Philippines or even in the US to a degree now. And I think all we can do is continue to highlight those abuses and continue to advocate with our colleagues from those regions in UN International Human Rights Fora.
Thank you, Niamh. Yeah, thank you. So, colleagues, if you have anything to add to some other questions you heard, if yes, please do. If not, we will move to the concluding part. So, I really would like to thank all of you, our brilliant speakers and presenters. Really, we benefited a lot, all of us. And it's important also that we didn't limit experience to our region only. So having truly international experience and sharing in your presentation, it's also a great asset. I like the format. We had some technical difficulties, but we overcame this. So, and it's also optimistic sign. In terms of the mainstream, yes, let's be optimistic. Let's not just return things as they were before the COVID times, but actually build on some positive things. The gains we need to sustain, and there are some. All of you actually indicated some great things we need to keep, as well as keep eye on the risks, because also all of you mentioned some risk areas in terms of resources or supply management, procurement, also human rights, neglecting key populations. So we need to be more pushy in defending these positions. With the advocacy efforts, with the resources we need to mobilize. The webinar is conducted within the framework of the SOURCE project, Sustainability of Services for Key Populations in 14 countries of Eastern Europe and Central Asia. So it's really relevant for the region, and we are greatly thankful for your amazing contribution. Really inspired. You made our day great, and we are wishing all of you, the speakers, also the participants, a great day, and keep track on this, so we can also follow up on this webinar. It would be not just one-off event. We can consider planning some other things, and also summarizing some practical recommendations and key suggestions based on the webinar. So keep watching us. Thank you so much. Thank you, Volodymyr, Fifa, Anton, and Niamh. Thank you. Our team, SOS project team, organized this. Those who were behind the scene, not visible, but very important for making this happen. Thank you. So we concluded.
Keep up the fight.